Our symposium today we have two presenters, and our symposium is let's see, where am I? Oh goodness, hold on. Okay, so we have two presenters. This is the Health and Safety Symposium, and our first presenter will be Abay Asfaw, and he's an economist in the Economics Research and Support Office at the Center at the CDC. He joined the CDC in 2008. Before joining the CDC, he was a postdoctoral fellow at the International Food Policy Research Institute and a consultant for the World Bank, Brookings Institute, World Health Organization, and the International Labor Organization. His current research includes the long-term consequences of occupational injury and illness on workers, family members, and society, economic incentives to reduce workplace injuries, effectiveness of regulation in reducing occupational injury and illness, and the impact on worker injuries and prescribing drug overuse. Our second, and Abay's presentation is going to be on do worker injuries receive opioid prescriptions outside the workers' compensation system, the case for private group health insurance. And Abay will go first, and his presentation will be a pre-recorded one. And the second presenter is going to be Maria Figueroa, and Maria is the director of the Labor and Policy Research at the Worker Institute of Cornell University School of Industrial and Labor Relations. Her work focuses on issues related to contingent and low-wage work, focusing on the impact of non-standard work arrangements on labor standards. She engages in applied research projects in close collaboration with labor centers in construction and housekeeping industries. Prior to joining Cornell in 2000, she worked as a senior analyst for the Teamsters Union and for AFSCME. Her work appeared in academic journals, book chapters covering labor issues in construction, healthcare, and arts and entertainment industry. She teaches in the Master's in Labor Studies program at CUNY School of Labor and Urban Studies. Maria holds a doctorate's degree in labor and policy from Northwestern, a master's degree from New York University, and a BA from the New School of Social Research. And her presentation will be on the impacts of policy changes on worker safety outcomes in New York City construction sites. So, well, first up again will be Abay, and his presentation was pre-recorded. We'll do that one first, and then I'll follow it up. We'll let Maria do hers, and after Maria's concluded, we'll take questions and hopefully get a good conversation going back and forth, and we'll try to go as quickly as we can because we really don't have a lot of time. So hold on, sit tight, and let me make sure I can get Abay's presentation up. Let's see, share, and here.
Good morning, good afternoon. My name is Abay Asfaw from CDC NIOSH. Thank you for joining us today. The title of my presentation is, Do Injured Workers Receive Opioid Prescriptions Outside the Workers' Compensation System? The case of private group health insurance. My co-authors are Brian Quay and Chia-Chia. Let me start by examining the motivation of the study. We know that workplace injuries are associated with acute and chronic pain. The literature also shows that injured workers are more likely to use opioids. For instance, the National Council on Compensation Insurance, NCCI, shows that half of workers with workplace injuries received opioids at their first medical visit. Another unpublished study from NIOSH also shows that workplace injuries had a 30% excess risk of leading to opioid prescriptions than non-workplace injuries. However, our knowledge about the impact of workplace injury on prescription opioid use is mostly limited to data from the workers' compensation system. This gives an incomplete picture about the impact of such injuries on opioid use. In this study, we tried to fill this research gap by examining the impact of workplace injury on receiving opioid prescriptions outside the workers' compensation system by considering the group health insurance. Therefore, the major objectives of this study are one, to examine the impact of workplace injury on receiving opioid prescriptions outside the workers' compensation system, particularly from employer-sponsored private group health insurance, and two, to study how long injured workers received opioid prescriptions after injury from group health insurance. The data source for this study is the market scan databases. Market scan data are produced by Truvan Health from over 250 medium and large employers and health plans throughout the United States, and it's available for subscribers. From the market scan databases available, we used the enrollment drug workers' compensation databases. If you want to learn more about the data, we can discuss it during the Q&A. In the absence of a randomized trial in which randomly selected workers are assigned to be injured, the second best option is to use quasi-experimental models. In this study, we used a quasi-experimental model called difference in differences, DID. As you can see in the equation, we are interested in coefficient beta 3. That means the coefficient of the interaction between injury and time. If you have also a question, we can discuss about the method in Q&A. When you come to measurement of variables, our intervention or treatment variable is incidence of workplace injury. We considered two outcome variables. The first one is a dichotomous variable that measures whether a worker received one or more outpatient opioid prescriptions from group health insurance. And the second one is its a count variable that measures the number of prescriptions received from group health insurance. We used the CDC national drug codes to identify opioid prescriptions. The main study period is 2 months before and 2 months after the index date of injury. I'll explain in a minute what index date of injury means. To examine the long-term impact of injury on opioid use, we extended the survey period to 1 year before and after the index date of injury, still in 2 months follow-up period. We controlled for covariates observed before the index date of injury, such as sex, industry. The data were organized as follows. Overall, we considered 3 years of data, 2013 up to 2015. We considered workers who were injured in 2014 and not injured in 2013 and 2015. Workers injured in 2013 were excluded because opioid use in 2014 can be the results of injury in 2013. Workers injured in 2015 were also excluded because the follow-up period is also 1 year after 2014. We also excluded workers injured more than once in 2014 because it would be difficult to establish a unique follow-up period for 2 injury dates. From the total of nearly 760,000 workers in the data who were not injured from 2013 to 2015, we randomly selected 96,160 non-injured workers. That is 5 times the number of injured workers as a control group. So our overall study included 19,232 injured and 5 times that of non-injured workers. Because there was no date of injury for non-injured workers. Therefore, we randomly assigned an index date, or we call it a pseudo-injury date, to each of these workers that corresponds to the date of injury of injured workers. In this graph, the vertical axis measures the percentage of workers who received at least one opioid prescriptions, and the horizontal axis measures the follow-up period. We have 3 study periods, 3 up to 4 months and 1 up to 2 months before the index date of injury and 1 up to 2 months after the index date of injury. We added the 3 up to 4 months before injury period to test the parallel trend assumption of the DID method. As you know, one of the basic assumptions of the DID method is that the pre-injury trend of the outcome variable should be similar for injured and non-injured workers, just as shown by parallel lines. The results show that 8.8% of injured workers received opioid prescriptions 3 up to 4 months before injury, and this declined by 1 percentage point to 7.8% 1 up to 2 months before the index date of injury. For non-injured workers, 6.1% received opioid prescriptions 3 up to 4 months before, and it increased slightly to 6.2% within 1 up to 2 months before the index date of injury. Overall, we observe a nearly parallel trend between the two groups, as you can see by the parallel lines. Therefore, we expect the same trend within 1 up to 2 months after the index date of injury if injury didn't have any impact on receiving opioids. As you see, the percent of injured workers who received opioid prescriptions from the group health insurance jumped to 17.9%. This is a 10.1 percentage point increase, or a 195% increase, while the percent of non-injured workers who received opioid prescriptions stayed more or less the same, or declined slightly by 1 percentage point to 6.1%. Therefore, the difference impact of workplace injury was 10.2 percentage point, and it was statistically significant. Our next outcome is average number of opioid prescriptions received from group health insurance. Again, the parallel trend assumption is satisfied, and similar results were observed for the number of opioid prescriptions. Within 1 up to 2 months before the index date of injury, the average number of opioid prescriptions received from group health insurance was 0.13 for non-injured workers. It slightly declined by 1 percentage point to 0.12 within 1 up to 2 months after the index date of injury. For injured workers, the average number of opioid prescriptions received from group health insurance increased from 0.17 within 1 up to 2 months before the index date of injury to 0.36 within 1 up to 2 months after the index date of injury. This was 112% increase and was statistically significant at less than 1% level. So the difference between the two cohorts of workers was 0.20 and was statistically significant. In the multivariable analysis, we include baseline covariates and estimated random effect logistic regression model for receiving opioid prescriptions, and a random effects negative binomial regression for number of opioid prescriptions. Controlling for receiving opioid prescriptions within 1 up to 2 months before the index date of injury and other baseline covariates, we noted that the odds for injured workers to receive opioid prescriptions from the group health insurance within 1 up to 2 months after the index date of injury was 5.1 times higher than for non-injured workers. In the case of number of opioid prescriptions, injured workers received 2.6 times more opioid prescriptions from the group health insurance within 1 up to 2 months after injury than non-injured workers. This is controlling for all. Finally, we followed injured and non-injured workers for 12 months before and after the index date of injury to determine how many months they received opioid prescriptions without any interruptions from the group health insurance. The DID results are presented in the figure. There were statistically significant post-index date of injury differences in the percentage of injured workers versus non-injured workers who received opioid prescriptions continuously for up to 6 months. Between 7 and 12 months from the index date of injury, there were still positive differences, but the differences were not statistically significant. To conclude, let us see the main takeaway points of the study. First, this is the first study that empirically examined the impact of workplace injury on receiving opioid prescriptions outside the workers' compensation system. Second, we clearly showed that injured workers are more likely than non-injured workers to receive opioid prescriptions, not only from the workers' compensation system, but also from their group health insurance. Third, workplace injury can be a risk factor for long-term opioid prescriptions use. In our study, 3.6% of workers injured in 2040 received opioid prescriptions from the group health insurance for 6 months continuously. Fourth, we observed a statistically significant difference in the pre-injury incidence of opioid prescriptions between the two cohorts. As you remember, 6.25% of non-injured workers compared to 7.76% of injured workers used opioids. This might indicate that opioid prescriptions can be one of risk factor for workplace injuries. Finally, studies that use only workers' compensation medical claim data likely underestimate the magnitude of the impact of workplace injuries on the opioid. Thank you for your attention, and then I can accept questions now. Thank you.
Okay, so we're back. I think we'll just slide right over into Maria's presentation. Yes, Maria? And then after Maria's done, we'll take questions from our participants in the audience. Yes. Oh, geez, I can't hear her.
Okay. I
Okay,
forgot
I
to
can hear you now.
unmute
Okay.
myself. Yeah.
Okay, I'm sorry. Go ahead. I'm sorry. Go
That's
ahead.
okay. No, it's my fault. Okay. All right, there we go. Thank you for having me on this panel. My study evaluated the impact of a new policy, which was enacted in 2017, actually, to mitigate injuries and fatalities in the construction industry of New York City. So let me give you some background first. Since 2010, the construction industry in New York City added more than 40,000 new jobs. But that came together with a significant increase in injuries and fatalities. Just between 2014 and 2016, the accidents involving injury and or fatalities in more than doubled. The majority of the injuries and fatalities occurred among so-called vulnerable workers, immigrant workers, and non-union, largely non-union workers. In order to address this issue, the City Council in New York City enacted a law, Local Law 196, And basically what the law did was to increase safety training requirements for workers in major building sites, 10 stories and above, or more than 100,000 square feet in area. The training requirements would be phased in over time. By March 1st, 2018, workers would be required to have at least an OSHA 10 card, a minimum of 10 hours of safety training. By December 1st, 2019, they were required, and they actually met this requirement, and they were required to have minimum of 30 hours, and supervisor would have to have 62 hours. By September 1st, 2020, they will be required to have minimum of 40 hours. So the monitoring and enforcement of the law is done through inspections, and fines and penalties are issued to employers, not to workers, in those sites in which workers are unable to show their card, right? That they have the safety card that is required. So yes, this law links compliance to issuance and renewal of permits, which is a sensible enforcement strategy that actually mirrors other initiatives that were implemented in the car wash industry and the nail salon industry in New York City. So it's sort of like an innovative enforcement strategy, right? So a key element, of course, in the whole policy is to increase access to training for workers who lack access, right? Those are the vulnerable workers, immigrants, and non-union workers. The way they do that is by certifying providers who can provide the new content that will be included in the site safety training, and also by providing funding to organizations that are called worker centers or day labor centers who have more access to the vulnerable workers or the target population for this policy. The structure that was set up for implementing the law involved the New York City Department of Buildings as the agency in charge of implementing and enforcing the law. So they created a new unit, construction safety compliance unit, who, which actually does the inspections and enforces the law. And they established a partnership with the New York City Department of Small Business Services, which is the agency in charge of certifying the providers of training and also of funding the day labor centers or worker centers, right, for them to train workers at no charge, to train immigrant workers, Latino workers, non-union workers at no charge. So the third piece of the structure is a safety training task force, which mainly plays an advisory role, but it includes representatives from unions, employers, and other city agencies, and one day labor center representative. So, you know, there is limited representation from the organizations that actually represent and serve the target population. The goals of my study were mainly to assess the impact of the new policy on outcomes in two main areas. And they are, one, construction workplace safety, right? Whether injuries and fatalities decreased or not significantly, right? As a result of the implementation of the law. And the other area is whether there was really an increase in safety training for the target population. So for that, I had to identify, success factors and barriers to implementation and assess the effectiveness of the newly required training program, right? And really, addressing the specific needs of the target population. So the methods that I used were mixed. I utilized quantitative and qualitative strategies. The data that I used mainly involved construction injury statistics from the New York City Department of Buildings. And I ran focus group sessions of non-union and largely immigrant workers who received safety training at 3 local worker centers in New York City. And I ran semi-structured interviews of worker center leaders, government agency representatives in charge of implementing the law, and also some of the members of the joint public-private advisory task force. For the analysis, I use a time series design, including a pre and post intervention periods, a simple OLS regression analysis to estimate impacts of implementation on injury rates, and I coded and extracted themes from the focus group and interview data. I use a logic model framework to evaluate the process and the outcomes. In terms of the results of the quantitative analysis, this is what I got in terms of being able to observe any impact from the implementation of the law. This chart includes the predicted and observed values for injury rates in post-implementation of the law. So the blue bar is the predicted value, based on my OLS regression, and the orange bars are the observed values, the actual values, right, for the injury rates. And what we can see is that initially, from January 2018 to September, there isn't much divergence between the two series. But starting in October, what you see is that the predicted values are consistently higher than the observed values. So meaning that there is something going on there, maybe yes, maybe not, this law is having some kind of an impact, right? And this second chart is just a simple examination of the trends and the levels in injury rates per month. And it serves to just to show, right, that the injury rates tend to stabilize in 2019, which is the blue line here, compared to previous years, especially 2018, in which we saw a big surge. And you don't see that in 2019. It tends to be more stable and mainly, lower. So in terms of the results of the qualitative analysis, the themes that I got from the focus group sessions were mainly about around a few areas. One about the benefits from safety training, right? Workers did say, yeah, that they felt empowered, and more knowledgeable, being able to identify risk and avoid near-miss accidents. Also, they felt able to train others, like new hires, and they really experienced a sense of empowerment and confidence to refuse unsafe work, right? And in terms, they also identify shortcomings, right, of the implementation and enforcement, like the lack of worker protections against employer retaliation, weak enforcement, and inadequate monitoring of employer compliance. For instance, these quotes that I picked illustrate these points. The supervisors would always tell us to go on the scaffold without the harness or the lifeline, right? After I learned in the OSHA training that this was wrong, I told them, but they hired me soon afterward. They fired me. So, and they tell us, if you don't like it, you can leave. I mean, this was something consistent, in all the focus group sessions, is a complete disregard most of the time on the part of the employers of the regulations, and a focus on holding the cards, right? And so the onus is on the worker to undertake the training, right? They have to take the training and have the cards, right? But there are also employers and managers that do not receive adequate training, but hold their certification cards, right? So again, some quotes illustrating this issue, right? Is sometimes contractors only get the online training for OSHA 30, but they don't really know the regulations, but they get the card. So when I raised the issue with my boss, he told me, don't worry, that doesn't matter. What matters is that I have my card. So there are also challenges specific to the informal economy. And that's something that, day laborers pointed out, very straightforwardly, that is much easier to deal with a regular employer in the formal economy than with an employer who is very elusive and very hard to track. And so my takeaways, injury rates did look lower, right, than would have been expected before the implementation of local law 196. But this can be attributed only partially to the new policy. Why? Because the labor organizations have already increased trainings prior to the implementation of the law. And prosecutors, like local DAs, had been strengthening enforcement already. And so all of these things were, already happening, right? And are obviously, conflating, right? With the impact of the law. And there are still significant barriers for the target population to access the training programs. The city did pretty limited outreach initially, created a lot of confusion in the industry, and the delivery methods still not adjusting adequately to address the issues of language and literacy barriers. There is also the unanticipated consequence that, employers prioritize holding the card rather than complying with safety regulations and worker protections. And then, some recommendations, the outcomes may be enhanced by increasing input from the labor organizations who were not really consulted in the design, or who were minimally consulted in the design of this law that was going to affect their constituents mainly. And also, it is important that the Department of Buildings increase interagency collaborations with agencies that are knowledgeable and experienced in enforcing and monitoring labor standards, because this is something that the Department of Buildings acknowledged from the get-go. They said, well, yeah, we will face challenges implementing this law because we're not really, we're not really in the business of protecting workers, right? We're in the business of making sure that the buildings meet the codes, right, that are required to protect the public, the general public, right? And so they're in completely different areas of work, and they just need to acknowledge that and cooperate more with the New York State Department of Labor and the New York City Department of Consumer and Worker Protection that has an Office of Labor Policy Standards. So the other key measure that they could take to improve implementation is to simply train the inspectors, the Department of Building inspectors in worker safety standards. That is something that will cost a lot of money, but that could, enhance outcomes significantly, because then when they go and do the inspections for the safety codes and they ask for the cards, right, for workers to have the card, they could also, check whether, there are other, pretty obvious safety violations on the site. So that's my presentation. I'm gonna stop sharing my screen. Let me see, just a sec. Okay.
Okay, so we're back. All right. So are there any questions that anyone, we don't have a large group, which might be better for all of us to just do this informally. Does anyone want to jump in from the audience? If not,
I would love to.
Oh, go ahead.
Sorry, if you don't mind, you can go ahead if you were.
No, go.
Yeah, so I'm Ben Kreider from Brandeis University.
Mm-hmm.
And my question is for Maria. I may have a question for Abay as well, but for Maria, my own research, this is really interesting. My own research is actually on worker centers and union collaboration in Boston. So we should talk, but I'm wondering if you could go back to you talked about the online training and the unintended consequence about the cards. Could you explain that a little bit about the online training? I didn't entirely understand that part, and I would enjoy hearing more about that.
Yes, there are two things going on with the online training, actually, and they are problematic because there are, the OSHA 30, OSHA 10 that are required, right? They are available online. So a lot of supervisors, prefer taking the training online. They can do it at their own pace and so forth, but there is nobody overseeing, the training process or proctoring, right? The learning process. And so that creates a lot of problems because they are not really, they're not really knowledgeable and they didn't receive appropriate or adequate training. So that's the one thing that is going on with the online training. The other thing that is going on too is that these 10 additional hours of training that are added to the OSHA 30, right? The DOB, the New York City Department of Buildings, was contemplating doing it online. And everybody rebelled against that, among worker advocates, because it's not a modality that is gonna work, particularly with immigrant workers, and who may not have access to computers, right? And so, yes, those are the things that are going on with the online modality. The issue of the unanticipated consequence, right, of prioritizing the holding of the cards is that created so many problems because, the supervisors, the managers, the employers, right, they were just requiring cards. And in many cases, they even bought the cards, in the informal economy. They even bought these cards for the workers, or they paid for the training of the workers. And then they would even keep the cards and fire the workers. Whenever the worker was fired or left or ended the project, they would say, oh, I will keep the card because I pay for this card. Right. And so, but the main issue is that they prioritize holding the cards, having the cards, right? Because that's all the inspector is asking for, right? And that's all what the inspector is gonna require, in order not to give them a fine, So, if they, so again, that's the issue that's going on with the unanticipated.
So Maria, I would like to come back to this compliance issue in a little bit, but if I could, Abay, I wanted to ask you a question about your research, and it has to do with, I think you said in there that, or what I want to know is, why is the pre-injury opioid use of injured workers higher than the non-injured workers? Abay, are you with us?
Yes, I am. Sorry, I was on mute.
Sorry, my phone.
Okay.
So did you get my question?
Yes, yes.
Go ahead.
Yeah, actually that's important observation. Probably where we didn't control for comorbidity, that can be one reason why the pre-injury level of opioid use for injured workers was higher. And the second reason can be opioid use can be also a risk factor for workplace injury. So that's why.
Oh, I'm sorry, you're freezing up on us, Abay.
Oh, I'm freezing. Sorry.
Yes. All right.
Can you hear me now?
I can hear you now. Yeah. So if you,
Okay,
I think you were saying something about why you had listed a couple of reasons about why the pre-injury.
Right.
Yeah. So I didn't get the second part of it.
Okay. The second part of it is that opioid use can be a risk factor for workplace injury. So those workers who used more opioids at the pre-injury level are more likely to be injured.
Oh.
That can be one explanation.
Okay, but that's a possible. But I'm curious
Right.
because I mean the implication is that people come to work because they're already on painkillers from having been injured, maybe,
Yeah.
and they're having run a higher risk factor for being injured on the job.
Right.
Yeah.
Right.
Okay. All right. Any more questions from our participants, our audience? Anyone out there want to ask another question? Yes, no?
If no one else goes, I might have another, but I'll give
Sure,
someone.
go ahead. Go ahead, Ben, yeah.
Okay. So for Maria, I'm wondering about this unintended consequences issue. That's a very common issue in policy implementation. I'm curious if you have ideas or conclusions from your research about how to overcome those problems. The online training thing is interesting to me because I used to work for a building trades union, and we found that there were these outfits that were doing the same things. They were like licensed mills for asbestos, and people would just cheat. So I'm curious what your ideas are and how to combat the problem in your case with the cards.
Yeah, that is, I think there is a need for more monitoring. I think more close monitoring, and sort of overall, there is a need to increase access to legitimate and adequate training, right? To certify providers, and that actually has been a limitation in the case of this new law. At the time when the first requirements phased in, there weren't enough certified training providers. It was a total mess. And so my sense based on this experience is that the Department of Buildings and the Small Business Services Department need to increase or strengthen their efforts in certifying, providers and monitoring the quality of the training they provide. And my sense is that will help in some ways mitigate the purchase of cars in the black market, right? In the informal economy. Yeah, and then the issue that the strong emphasis in just holding the card is the other problem, right? That maybe they should change their approach and say, yes, this is a key requirement, right? That people have the training, but also, say that, well, we're also here to look at whether you're in compliance, with the safety codes, right? Perhaps, changing their approach completely and communicating that, right, to the employers would be helpful. That would be my recommendation.
Maria, I have one quick question for you. Well, it's not really a question as much as an observation, but so I'm a co-founding member of New Labor, which is a worker center based out of New Brunswick. And New Labor has done health and safety related training and research for about 20 years. And one of the things that we did a few years back after post Sandy, after the hurricane and the rebuilding was going on, was that we trained workers to be what we call health and safety liaisons, right? So, and I'll skip the details here and just say that one of the things that we figured out early on was that our trained safety liaisons did not really feel empowered until they got to a place where they had some communication, understanding, and developed some relationships with the people at OSHA who do the enforcement, right? So what happened was they gained confidence as liaisons when they felt like they could pick up the phone and call an OSHA inspector, and the inspector knew on the other end of the line that it was the New Labor Safety liaison who had been trained. And so it empowered them in a couple of ways, right? One was that it would alert the inspector that maybe there was a problem they needed to pay closer attention to. And it would also alert the employer that this person who's calling is someone who has some leverage here that most everybody else in the job site might not have. So my question is, are there any efforts, or has there been a much work in terms of getting the workers or the organizations that represent the workers to be more collaborative and to work more closely with the agencies that do the enforcing, or the people who are on the ground that actually go out and inspect?
Yeah, yeah. There's been efforts actually in developing similar strategies here, especially one worker center in Brooklyn does follow the exact same model, right? Of the safety liaison, the worker safety liaison, and they do go and conduct the audits, and that all has been working fine. There are only two problems there, right? One is related to OSHA, right? To the fact that they've been defunded pretty much, right? And so it's a problem. We need to deal with that in some ways at one point, right? And the other issue is that it's been really challenging for the worker centers to have input in the design and implementation. So far it's been just sort of like a window dressing kind of thing, yes, we have this person, who is the executive director of one worker center, right? And here we have, the entire building trades and the employer association, both union and non-union, right? And the agencies. So it's like, if they're really trying, to mitigate injuries among vulnerable workers, they have to have more input, right? From the worker centers. But yeah, so that is, we get into a lot of political issues there, and challenges when we get there. Yeah, and yeah, getting to where we are hasn't been easy either, right? It's been a rocky road, and a lot of tension, even with the building trades. But even though we're all trying to make things better for the workers, right? Because the building trades were very instrumental in making this happen, which is great, right? They were like really supportive of this. But yeah, that comes with tensions too, right? And so yeah, so it's a work in progress.
So, Abay, I had another question for you. In the study that you did, was the population of people, of folks that you looked at, were they representative of the larger whole of all workers? And sort of piggybacking with that, I'm curious about, it didn't, I guess, I'm assuming here that the study didn't really break things down along the lines of demographics, typical demographic lines. So I'm curious about those two things, if you could weigh in on those.
It's interesting. The data we used, the market scan data, and it's available only for those who subscribed it. The one thing is that the data is representative of workers who have group health insurance. That means workers who do not have private insurance or insurance that are not provided through their employers are not part of that. Otherwise, if we use the weight, then the coverage will be the total number of workers who have employer-provided health insurance schemes. So if you see, for example, industry, construction is not well represented. It's not really representative of the working population of the United States.
Okay. So then their study didn't really, I mean, well, obviously Maria's work is focused very much on construction, but your study couldn't really pull that kind of information out given who the group was. Okay, given the database. All right. Okay. All right. Well, let's see. The other question I had for you, Abay, was that do you have any questions on the opioid use of workers from workers' compensation system? And I'm going to ask you about workers' comp because I'll just say that my own personal experience with workers' comp, going back to some years ago at New Labor, we were trying to get some data on workers' comp, and we were trying to communicate to workers that they were eligible for workers' comp. And here in New Jersey, workers' comp is a big black box. Like it's like, I don't know, you can't get very much information out of them in New Jersey about workers' comp, and the data is sketchy at best and difficult to get at. So I was curious about the workmen's compensation system in relation to your study and your work.
Yeah, we have another project in Ohio in collaboration with the Ohio Workers' Compensation System. So we have access data to the all medical records related to workers' compensation. So we're doing some research there. But here the objective was, it's much known that injured workers are more likely to get opioids from the workers' comp system. That's obvious. But in this study, what our interest was to see if these workers also receive opioid prescriptions outside workers' comp. If they receive, for example, from their group health insurance, etc. As you have said, workers' comp covers the bulk of all opioids for injured workers.
All right. Any questions from our audience? Any more questions? Anyone?
Yeah, this is.
Go ahead.
I'm Ariane Higovish from the Institute for Women's Policy Research. I'm really sorry I came in right at the end of Maria's presentation. So you may have talked about all this. We do particularly work on women in the trades, so the construction issue is particularly interesting. So I'm really wondering about now with the COVID and post-COVID situation. I know in New York, most sites have been closed, but what we hear is that kind of a big difference in the kind, some sites are very good, a lot of them are not. And also the other question is, I think the focus on the OSHA certificates as one way of looking at health and safety is really interesting. We know that, for example, Turner in construction have people who go around also on diversity and equal opportunity and check issues around harassment and workforce environment and all those type of issues. So I'm just thinking what the experience is beyond the kind of compliance, non-compliance around the certificates.
Okay, so you've raised a couple of issues there that I think, given our time, what I'd like to do is give Abay and Maria an opportunity to give us some closing remarks. But if you could put those closing remarks in the context of, and this is a big ask, of our current COVID-19 pandemic situation, and also in the context of issues around equity, given that the world is on fire over some of these issues, literally, and it's not just, it began in the U.S., but it's gone global. So, inequality and COVID-19 and your closing comments, if you could pull those together, well, that would be great. And I'll, do the best you can. So we'll start with Maria and then we'll conclude with Abay. So Maria, go first.
Okay. And in doing that, I will address your questions, which, I will try my best. And yes, in the course of the research that I've been doing with worker centers, issues of inequality and harassment against women and men, emerge quite frequently. And that's why, I think that's where the relevance of my study lies too, because and the work that I do with worker centers in the area of construction lies, because these workers who are at the margins, right, of the labor market are often discriminated or receive differential treatment because of their immigration status or because of their race, right? And yes, that has created, a lot of problems, not only for them, right, but also for society as a whole. Right now, with the COVID-19 and even before COVID-19, their issues, their safety and health issues were really, public safety issues for everybody, right? And now even more so, right? So if they are not addressed, they are gonna become just bigger public safety problems for everybody. So, and they're not being addressed. That's the problem that we're seeing right now here in New York City, is that yes, we're reopening the economy, but nobody is addressing these pre-COVID vulnerabilities, right? That these workers have experienced all along, right? And so, yes, unfortunately, in a very bad way, these two issues got linked, right? Public safety and inequality. I am completing another project now with a worker center in Staten Island, and we're confirming everything that everybody has said about the city as a whole, that, the COVID struck harder in the areas where poverty rates were higher, where, where you had concentration of people of color, right, and immigrants. And so, yes, these two things are connected in a very vicious way, and we have to address them, and we're not, definitely not. Worker safety is not at the top of the priority of our government representatives, our policymakers, our governor, and so.
Okay.
Yeah. As far as opioid is concerned, actually it's the white middle class of the working population, which is very, very disproportionately affected by the opioid epidemics. As far as COVID is concerned, we have started a new project to identify which group of workers, especially by occupations and by age and by race, are more likely to be exposed to COVID-19. If you know, using the ONET data developed by the BLS. So we have a new project on that to see if COVID return to work would disproportionately affect different people at different occupation, race, education level, and state. Thank you.
All right, thank you. Thank you, Maria. Thank you, Abay. I would just give my concluding piece here would just be to say that here I can only tell you what's, there is a level of frustration that I could hear in Maria's voice about where we are in relation to worker health and safety. And that, yes, it's always been a problem, especially for vulnerable workers, even more so. And now with COVID-19, and we have, I still don't think OSHA has issued a citation to anyone, if I'm not mistaken. And we're into this months now. There are no standards, there's not an emergency standard that's been put in place by OSHA. And that's not to say, I mean, I've worked with the folks at OSHA in our region for many years. They're good folks. They've just been disarmed or basically told to go sit on the bench and be quiet. And, that's what's going on. So in the meantime, what we're trying to do in New Jersey is force the governor to pass an executive order giving workers the right to refuse unsafe work, especially unsafe work that has anything to do with exposure to COVID-19. So I think we're left with the state level here in the U.S. right now to try to protect workers and making demands on at that level. It's probably the best we can do right now. But it is frustrating. But I also think that at the end of the day, it really is like everything else that's happening in the world around us. People are taking their issues to the street. And I think that workers have to be more vocal, and we have to help them organize better to communicate, get their voices heard. And we have to be out on the street with this issue. And it is important because it doesn't just affect vulnerable workers, it affects all workers at this point. So we need to get out there and do more of that as researchers, as activists. But I think on the positive end, it's possible, and it looks like the potential is there right now for us to do good work. So thank you all again for your efforts and your work, and thank you all for participating. And that's it. Thank you very much. See you all.
Okay, thank you. Bye.